Dr. Ken Landau. Thanks for watching. Let's talk about the ACL. The ACL is the anterior cruciate ligament. You can tear it or sprain it, especially during sport or exercise or motor vehicle accidents. Ligaments are just strong bands of connective tissue that tether one bone to another. The ACL is one of two ligaments that cross in the middle of the knee. They connect the thigh bone, which is the femur, to the shin bone, which is the tibia, and they add functional stability and strength to the knee. ACL injuries are very common. They occur about 50% of all knee injuries, significant knee injuries, about 200,000 to 250,000 a year. Surgeries performed about 100,000 of these individuals, but our concepts of who needs surgery are undergoing some change. About 50% of ACL injuries involve some other structure of the knee. It's what we call the unhappy triad or the terrible triad. It involves not only the ACL but also the medial meniscus and the medial collateral ligament, but you could also have some damage to the articular cartilage or to the lateral collateral ligament, or even develop a bone bruise. We have three bones that form the knee joint. We have the femur, which is the thigh bone, the tibia, which is the shin bone, and the patella, which is the kneecap. And we have the bones connected to each other by the ligaments. We have four ligaments in the knee. They act like rope. They hold the knee together. They keep the knee stable. So we have the collateral ligaments that are on the sides of the knee. They prevent the sideward motion of the knee. They brace against unusual movement. We have the medial collateral ligament on the inside of the knee that prevents the knee from bending inward. And we have the lateral collateral ligament on the outside of the knee, and that prevents the knee from bending out. Then we have the cruciate ligaments. They're on the inside of the knee, in the center of the knee. Cruciate refers to the shape of a cross, and that's what they do. They cross diagonally in the middle of the knee. The anterior cruciate is about 1/3 to 1/2 inch in width, about 1 1/4 inch in length, goes from the back of the femur to the front of the tibia, so back of the thigh bone to the front of the shin bone. The posterior cruciate just goes the opposite direction. What they do is they control the back and forth movement of the knee. The ACL prevents the tibia from sliding forward on the thigh bone. It also provides some degree of rotational stability. Greatest risk of injury? Well, it's in athletes, female athletes between the ages of 14 and 18, male athletes between the ages of 19 and 24. But injuries can occur in anybody involved in physical activity, or you can be doing nothing other than fall and injure your ACL. Seems, though, that most people who damage the ACL are involved in some kind of physical activity, but now even the older athletes are at risk. Oftentimes they've added a little bit of weight. You have the functional demands of aging. Just like your skin ages and you get the wrinkles, well, the same thing's happening inside the bones and joints, inside the ligaments. So you have a tendency to have collected a bunch of cartilage damage as you grow older, some meniscal damage as you grow older. You get less healing potential. You can't tolerate the load that you used to be able to tolerate. The stem cells that allow healing of the ligaments and the cartilage to occur, those are wearing out. They're not dividing as rapidly. The mean age for reconstruction now is about 29. But ACL injuries and repairs in people over age 40 have doubled recently. That's actually second only to the increase in incidence of ACL injuries in children less than age 14. Now, somewhere between 40 and 80%, about half of all the injuries, involve non-contact mechanisms. Everyone thinks of football and the side blow to the knee. Well, about half of the injuries don't involve any contact. They involve pivoting. So when your foot's firmly planted, but your bones are going in opposite directions, the bone of the shin and the bone of the thigh, or cutting when there's rapid change in direction, often associated with sudden slowing down or stopping. There's jumping where you land awkwardly, oftentimes when you're improperly turning or twisting. Then we have overextending the knee. We have motor vehicle accidents. There are a lot of ways you can injure your ACL. But basically, an injury to the ACL can be just stretching the ligament but not tearing it, leaving it intact. Or you can have a partial tear, a complete tear. Most injuries occur in the middle of the ligament. What happens is you pull the ligament, you stretch it, and it tears right in the center, or sometimes it's just pulled right off the bone. There are some risk factors that suggest that you're at increased risk. So people who have poor physical condition or lower core strength, or people who are fatigued when they're exercising, people who are exercising in extreme cold or playing on turf are more at risk. People, young children, who are involved in earlier and more intense physical activity and participation in sports, they seem to be at increased risk. And people wearing improper footwear for whatever activity they're performing, those people can increase the risk. Those are all modifiable factors, and so is the birth control pill. Women who take the birth control pill seem to protect their ACL. You have some non-modifiable factors that increase the risk. So just being a woman increases your risk somewhere between 2 and 8-fold. On average, about 3 times more injuries to the ACL in women than in men. There's some anatomic differences. There's alteration in the pelvis and the ligaments, the alignment. We have some changes in muscle strength and hormones, obviously, neuromuscular control. Well, before puberty, the likelihood of injury to the ACL is the same in boys and girls. After puberty, because of increase in the estrogen and the relaxin hormone, seems to be more joint laxity and more extensibility of the soft tissues. So if we look at female college athletes who perform the same kind of activities, if their relaxin level is greater than 6 picograms per milliliter, then we find that those women have a 4-fold increase in the number of ACL injuries compared to women who have lower levels of relaxin. And then the female pelvis is wider, so that means that there has to be more angle to the femur, the thigh bone, as it goes toward the knee. And we have something known as a Q angle that's greater in women, 17 degrees, compared to men, 14 degrees. And in women, the ACL is smaller, so it tears with less loading force. And the quadriceps muscle is an antagonist to the ACL. Well, women more often recruit the quads. They put more strain on the ACL. And we have 4 neuromuscular imbalances that increase the risk in women. And those imbalances are associated with the way they jump and land with the knees straight and collapse toward each other. So some women have ligament dominance, where the ligaments, not the muscles, absorb the impact. Other women have quadriceps dominance, where preferentially they use the quadriceps to stabilize the knee, but when they do that, they pull the tibia or the shinbone forward. That puts extra strain on the ACL, and we have leg dominance, where women land with more weight on one leg compared to men. We have trunk dominance, where they're more likely to land tilted to one side, and that increases the force and puts a greater rotational torque on the ACL. And then we have differences in bone morphology and your genetics and the neuromuscular control and the hormones between the men and the women. So the people who are involved in certain activities, certain physical activities, seem to be at highest risk. So women who are involved in gymnastics or soccer or lacrosse or even basketball. Actually, basketball injuries in women to the ACL, those occur about 5 to 8-fold more frequent than in men. Men, the greatest risk in sports involves football and basketball and lacrosse. And now we have ski-related injuries. And fortunately, ski-related injuries, because of advances in the ski equipment over the period of the past 30, 40 years, have caused a change in the pattern of injury, especially to the leg. So about 40 to 80% of ski injuries are going to involve the leg. And specifically, they're going to involve the knee in about 25 to 40% of all injuries. And the ACL is still quite commonly injured, but not nearly as much as it was 20 or 30 or 40 or 50 years ago. Median age in people involved in alpine skiing for damage to the ACL is about 30. Most at-risk individuals are children and adolescents and people over age 50. And remember, ACL injuries occur more commonly in female skiers than in male skiers. When a male skier injures the leg, tends to be a fracture. And interestingly, in women, when they involve the leg, it's the non-dominant leg. So right-handed women tend to more often rupture the ACL on the other side, on the left side. You have to remember, with age, lots of changes are going on in your bones and the ligaments. The ligaments are going to alter in their thickness, going to be altered in their thickness and their structural orientation of the collagen, just like getting the wrinkles as you get older on your skin. Well, the same thing's happening again inside the tissues. You're going to have more mucoid degeneration. The cells aren't going to be as active. You're going to have a deterioration in the cell themselves and in the composition of the extracellular material, and that's going to lead to a decrease in the mechanoreceptors, and they're going to change in the morphology and the number, and that's important because that's what controls how much force you expend on your knee or any other area of your body as you get older, because your muscles don't require constant thought. I'm going to swing my leg, I'm going to slow my leg down, I'm going to stop moving. You don't think about any of that. That's all done automatically. But as we get older, the ability to do that automatically tends to become less active. And as a result, we get injured more often, and then we don't even heal as well after some sort of an injury or even after surgery. Well, what are the symptoms? The symptoms, you hear a pop, a sensation of tearing. You feel like your knee is giving out. Pain's often quite severe. It's in your knee. It's too painful to bear any weight oftentimes. Frequently, there's swelling and an effusion that occurs either immediately or within 2, 3, 4, 6 hours. Decreased range of motion. You have the feel that your knee is unstable and gives way with weight bearing. There's tenderness right at the joint. Can have some discomfort walking, but pretty soon the pain and the swelling over a couple days tend to reduce on their own, but still you may have some instability if you resume normal activities, if you start to walk or involved in other activities. The ligament doesn't stabilize the joint anymore, doesn't prevent the tibia from moving forward on the femur. So we have some shifting, some instability. Now, physical examination is often all that's needed to make the diagnosis of an ACL injury. Sometimes you do some other tests in order to rule out a fracture. And as a matter of fact, about half of the people may be misdiagnosed early on, the first or the initial evaluation in the emergency room, even in a trained sports emergency room, orthopedic emergency room, simply because there's a change over a period of time. So you might need sequential examinations. We have something known as the Lachman test, where you lie on your back, your leg is flexed a little bit, your knee is flexed by about 30 degrees, and the doctor pulls forward on your shinbone, and if it comes forward, you got an issue. Or we have the anterior drawer test. That's where you have your hip flexed by about 45 degrees, the knees flexed by about 90 degrees, your foot's flat on the table, and the doctor again pulls the shin. If it comes forward, you got an issue. Then we have the pivot test, where the doctor puts some torque on the joint, and we have the lever test, where the doctor puts the hand underneath the upper part of the shin bone and pushes down on the thigh bone. And if the foot doesn't rise from the table, you've got an issue. That's the lever test. Well, do you need an x-ray? Well, most people get an x-ray. There are some rules about getting x-rays. Probably too many are done. And certainly if you're going to have a CAT scan or an MRI, you don't need the x-ray. MRIs are pretty much strongly recommended. They show not only the extent of the ACL injury, but they also show or identify associated damage, maybe to the meniscus or to the articular cartilage or to the collateral ligaments. But sometimes when the MRI is performed, if there's a lot of bleeding into the joint, then it could obscure the tear of the ACL. Well, the injury to the ligament, oftentimes referred to as just a sprain. So we grade them, grade 1, grade 2, grade 3. Grade 1, it's mildly damaged, it's slightly stretched, but it still is able to keep the joint stable. Grade 2, it's been stretched. The ligament is really to the point where it becomes loose. We call that a partial tear. It's relatively rare. Most are grade 3. That's complete tear. You have the ligament split into 2 pieces. It's unable to keep the joint stable. We have most of the ACL injuries fall into that group. So the therapy acutely, it's called RICE, R-I-C-E. It's an acronym. It stands for rest, ice, compression, and elevation. That's the standard. But the goal of the other part of therapy is going to be to restore the knee function, to decrease the abnormal knee movements, to address any psychological barriers that the person has to going back to performing some kind of activity, because a lot of people lose confidence, lose trust in their knee. They become worried and they don't want to do those physical activities that they previously enjoyed. And we also want to reduce further knee damage, more injury to the knee, and we want to prevent the development of osteoarthritis that may occur. And we also want to obviously increase the person's quality of life. So after the injury, you can walk even with a fully torn ACL, but you have to avoid twisting or turning or sudden movements, because a sudden twist can lead to either buckling or re-injury and further damage. So you shouldn't participate in those kinds of sports that are going to require some kind of lateral movement or quick turns. And certainly if you're involved in an activity and your knee swells or it becomes painful, hey, you don't have to be an Einstein. Stop that kind of activity. A lot of people like to wear braces, and people believe, doctors and patients, that braces perform an important function. They give stability. Well, most braces don't do that. We don't have the evidence that they're anything more than a placebo. But people keep using them, and that's okay, because they don't seem to do any harm. Crutches and canes can reduce the weight bearing, and that seems to be pretty good. So now we have 3 options for therapy. And the option that you pick depends on the doctor you pick. So there are different areas of the world that have different kinds of therapy that they tend to perform. And as a matter of fact, the same kind of therapy might not be recommended if you happen to see a different doctor even in the same city or even in a neighboring city. So irrespective of what you do, physical therapy is going to be a major component of your healing process. So some people opt for just rehabilitation, physical therapy. They say that's the primary goal. I want to avoid surgery. And we'll have surgery only if after the physical therapy, after several months, my knee is unstable. Then I'll consider it. That's quite okay. Some people just plan on, hey, I want the surgery, and then I'll go have some rehab. I want to get better instantly. Well, you don't get better instantly. But some people pick the surgery and then follow it by rehab. But a more common sense approach is going to be physical therapy first. And if you want surgery, you can plan on surgery. And then you have to go back to post-operative rehabilitation. So you can delay the surgery or just avoid it altogether. Or you can have surgery and then you can have rehabilitation. And as a matter of fact, for the overwhelming majority of people, it probably doesn't make all that much difference which one you choose. So if you don't want surgery, that's okay. For younger athletes, probably they're going to have surgery. For older, less active people, chances are they might not need the surgery. A rule of thumb from about 25 years ago is 1/3 of the people who are copers, they can resume their previous recreational activities without anything more than the rehabilitation. 1/3 of the people who are adapters, they're going to avoid surgery, but they'll modify their physical activity. And 1/3 of the people are called non-copers. They require reconstruction because of recurrent giving way in the ACL. So they need it. So what is the predictor of how well you're going to do after surgery? Well, it's the preoperative quadriceps strength. So it seems that those people who have strong quadriceps muscles in your thigh, the front part of your thigh, well, they have a faster recovery and they have a greater return to function, whether they have surgery or whether they don't have surgery. So irrespective of what your plan is, it seems that rehabilitation first, strengthening first, makes an awful lot of sense. And then if you have functional instability, yeah, after your rehabilitation, you could consider some surgery. But the rehab after surgery seems to be more demanding than the rehab if you don't opt for the surgery. And the outcome varies from patient to patient, depending on the activity level, depending on the degree of injury, depends on the quality of rehabilitation. And typical rehabilitation programs aren't terribly well thought of by the experts. They tend not to be very high quality rehabilitation programs. So You want to make certain that you're in an appropriate rehab program if you're going to go that route. And if successful, actually, it's every bit as good as you're going to get with surgical repair. And actually, women seem to fare better if they undergo just the rehabilitation rather than having surgery. And especially for women over age 40. Women over age 40, if they have the surgery, they're at increased risk for later meniscal tears and arthritis. So it seems that for those individuals, maybe it's a good idea to avoid surgery if it can be done. Now, the rehab used to be based on simply time. You would do rehab for 3 months, then you'd be done. Now we've gone to, no, that's not appropriate. We've gone to the criteria of the rehab. You have to achieve certain levels of success, and we divide it into about 5 different areas, and you have to pass one area before you can go into another. And it doesn't matter how long it takes, but you have to pass the one before you can get into the other. And it has to do with the ability of the capacity of your tissues to heal. The biologic capacity has to do with the structure and the function of your knee, and all of that is very important. And as a matter of fact, the rehab for people who undergo just the rehab is shorter than the people who undergo the surgery and then the rehab. So you could take some non-inflammatory drugs for pain, like the aspirin and the non-steroidal anti-inflammatory drugs. You have the structured physical therapy, where you strengthen the core muscles and the quadriceps muscles and the hamstrings and the hip abductors. You regain confidence. We improve the neuromuscular training. That's an umbrella term. That means the core strengthening. That means perturbation training, so that while you're exercising, a shift in the floor, a shift in the speed, a shift in the distance, a shift in the number of repetitions or the duration of activity, all that's important. Balance training, agility drills, all of that important to go from one stage to another in order to determine if you're going to do well. So we want to strengthen the quadriceps. We want to get them equal on both sides. Then we want to have you be able to hop and hop symmetrically. And if you can do that, then you can probably ultimately return back to your physical activities. We had the Canon trial, K-A-N-O-N. It was done in Sweden. It was published in the New England Journal in 2010. Compared about 121 people who had just the rehab with optional delayed surgery to people who underwent surgery right away and then had their postoperative rehabilitation. And you know what? At 2 years and at 5 years, as far as pain was concerned, as far as symptoms were concerned, as far as the rate of need for meniscus surgery, physical activities that the people were involved in, and the x-ray changes in the joint, didn't make any difference. Both groups were the same. Surgery group did not come out any better than the rehabilitation with optional surgery if necessary. So we need time to assess, time to see how the person heals. And we know that older people are going to heal less well. They're going to have decreased muscle strength. They're not as physically active. We know that ACL reconstruction is traditionally recommended in order to get back the anterior-posterior motion and reduce the knee laxity and reduce the rotary movement. That's in young, healthy people. But actually, we know that if we evaluate the evidence, there isn't any evidence that really suggests that those people do need the surgery. But surgery is recommended for a lot of top athletes. But again, it's done without really solid evidence. It's just recommendations. As a matter of fact, the American Academy of Orthopedic Surgery, they have clinical practice guidelines on ACL injuries. Say, well, yeah, we'll probably do some surgery if you're 18 to 35 years of age, if you happen to be active, but they don't define the level of activity. And there's no significant evidence-based data that says what you should do in people over age 40. So early reconstruction can be done within 10 weeks compared to delayed reconstruction, but there's no difference in the ultimate outcome. So you don't have to feel that you're rushed to have surgery, because remember, the outcome doesn't seem to make all that much difference. So if you do opt for surgery, and 100,000 people opt for surgery every year, 95% of the people in the outpatient setting, arthroscopic surgery, you have to have a graft typically, and the graft is going to act as a scaffold for new ligamentous growth, and you could have an allograft. That's a cadaver donor. So the doctor goes and buys it from the medical supply store and eliminates the need to harvest any tissue of your own. So that means a shorter surgery time, but it means increased cost. And it seems that allografts have a higher rate of graft failure and an increased rate of rupture, especially in young individuals. And then there's very rare possibility of HIV or hepatitis C or some other kind of disease that might be transplanted from the cadaver to you. So a lot of people like to go for autograft. So an autograft, your own tendon can be harvested. So it could be your hamstring tendon. Well, that's relatively easy to do, fewer problems harvesting the hamstring tendon than the patellar tendon, but we could use the patellar tendon. There's less graft failure if the patellar tendon is used compared to the hamstring tendon, but there's more postoperative pain. Or the quadriceps tendon can be used. There's less damage to the site of harvesting the tendon compared to the patellar tendon. And we can have a single bundle or double bundle harvesting or repair. And we can have variations in the surgical technique, the drilling, the screws, a lot of surgical technique involved. In the old days, they used to just suture the ACL back together again. But that's been out of favor for several decades because while it worked for the initial year or two, by 5 years, didn't work anymore. So the factors that determine whether you need surgery, the level of sports, the job that you have, but maybe it's not so appropriate for really young children because it might injure the growth plate. So oftentimes surgeons will delay the surgery until the child gets to the age where the bones mature, or sometimes they just modify the surgical technique. But there's no significant change in either the subjective or the objective measures related to the timing of the surgery. The American Academy of Orthopedic Surgeons suggests that if you're going to need surgery, you probably should do it within 5 months of the injury. So their guidelines say that you should have probably the initial 12 weeks after the injury should be non-operative treatment if you have an isolated ACL injury. Then you should reevaluate. So you should just have the rehab for the first 3 months. Then you decide whether you need surgery or not. Now, maybe if you have the surgery before 12 weeks, it's going to reduce the later damage to the medial meniscus and to some of the cartilage. But actually, it's not all that significant, so that the overwhelming majority of opinion appears to be rehab first. You could have some surgical complications. Surgical complications could be a wound infection or a DVT, or you might have delayed deep joint injury, postoperative bleeding into the joint. Sometimes you're unable to contract the quadriceps fully, and sometimes there's some problem with limitation of movement because of the incorrect positioning of the graft. That's actually the most common surgical error. And sometimes you get scar tissue that forms inside the joint, and then that can be painful, and it can restrict your range of motion. You could have re-rupture. Then we have the brace issue again. So does a brace after the surgery help? Again, we don't have any good evidence that it does. Can you re-rupture the ligament? Yeah, that's certainly possible, especially in male football players and female gymnasts and soccer players. Also relatively high in young individuals and in older individuals. But it doesn't seem that in those individuals who undergo rehabilitation, that they're at any greater risk for having any greater damage later on than people who have early ACL repair, early ACL surgery. And actually, in a 2014 study, re-injuries were more common after surgery, 24%, than they were after rehabilitation alone, 9%. Now, what about return to play? You've had the injury, you've gone through the therapy, whether it's just rehab or rehab and surgery. Now you want to get back to whatever your physical activity was. Well, actually, only about 50% of the people are going to return to the same level of activity or a higher level of activity after the ACL surgery. Typically, there are 2 Tegner units lower. The Tegner unit goes from 0 to 10. 10 are the high-level competitive athletes. 0, people who are bedbound. 5 are people who are involved in heavy labor or competitive sports cycling. So 2 levels less would be kind of typical. Actually, when they looked at European professional soccer players, these people, after surgery, they're well motivated, they have the best rehabilitation and the resources. About 93% of them can return to play, but only 66% of them going to return to the same level of play. So if you have the surgery, you should delay getting back to the same kind of activities for at least 6 months. That's how long it's going to take to optimize the biologic graft incorporation and get the outcome you really want. If you return before 9 months, you're going to have an increased rate of injury. So we have some criteria for return to play. And that means you have to have symmetric quadriceps strength, and you have to have symmetric performance on the hop test. And then often they add on a reactive agility test and sometimes a change of direction test. And if you meet all of those criteria, the likelihood of re-injury within a period of 2 years is only going to be about 5%. But if you don't meet those criteria, the risk of re-injury is about 33%. Now, knee osteoarthritis can occur whether you have surgery, whether you don't have surgery. It's more common in people who weigh a little bit more, who are physically inactive, and who have weak quadriceps muscles. So you can somehow control your risk by controlling your weight and performing some quadriceps strengthening exercises. So the incidence of osteoarthritis anywhere between 0 and 100%. And the reason it varies so much is we have to distinguish between the osteoarthritis that we see on an X-ray and your complaints related to the osteoarthritis. So a lot of people develop osteoarthritis that we can find on an X-ray, but they don't have any symptoms. Well, that same factor holds true with the ACL injury. There's a lot of X-ray osteoarthritis that's asymptomatic, totally asymptomatic. The only consistent risk factor is if your meniscus is operated on, then that's going to increase the risk of osteoarthritis. Now, one point on knee laxity. Knee laxity refers to you lying down on the table and the doctor either manually or with the device seeing how much movement there is in the tibiofemoral joint. But that doesn't account for any control due to the surrounding muscles. So much more important than the knee laxity, or the ligament laxity, is the functional stability. If you have functional stability, it doesn't make any difference what the level of laxity is in the doctor's office. If you have functional stability because you have good neuromuscular training, you can return to sport with your rehabilitation alone, and there's not any difference in the outcome whether you have surgery or whether you don't have surgery. Actually, the worst outcomes are in people who have the surgical repair and also have meniscus or cartilage damage. So basically, that's the story of ACL injuries. It's a very common problem, especially in athletes, but surgery is not always the answer. And in fact, with injury limited to the ACL, rehabilitation for up to several months seems to make a lot of sense. And it often is going to be able to avoid some of the prolonged rehabilitation that follows up in the aftermath of surgery. So if you suffer an ACL injury, you ought to get several opinions to see what seems to be the best for you. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified when we post new videos. I appreciate your interest. I'm Dr. Ken Landau.